Hi, everybody. We're just going to wait a few more minutes while people continue to join us online. All right, well, we've got a packed program for you this afternoon, so I think we might get going. Good afternoon, everybody. It's my pleasure to welcome you here to this third of our NeuRAtalks webinar series for 2021. I'm Carole Renouf. I'm the Executive Director of NeuRA Foundation. Thanks for joining us. We're going to be holding just one more of these sessions between now and November, and we'll be sending you a follow-up email after this one to alert you to this, and please join us again and share the link with family, friends, and colleagues. And if you are still in lockdown along with us, hope is coming and restrictions are easing. I'm going to aim to structure this session so we've got around 25 minutes discussion with our panelists, with me first, and then followed by around 20 minutes for you to ask questions. You probably know the drill if you've joined us before. Please don't wait till I throw the floor open to post your questions. Pop them in the Q&A feature, not the chat box that's disabled. And please don't raise your virtual hand. Just use the Q&A along the way, although we won't pick up your questions till later in the piece. So today we're going to be diving deep into NeuRA's research into falls, fractures, and pain. What do these three areas have in common? The critical importance of mobility. Movement is the key to preventing falls, recovering from fractures, and managing pain. So now let me introduce you to our panelists, all professors who do research at NeuRA and who also teach at the University of New South Wales. Firstly, Professor Jackie Close. Jackie is a geriatrician practicing at the Prince of Wales Hospital and is clinical director of the Falls, Balance and Injury Research Centre at NeuRA. She advises on aged health on too many to state, on many state, national and international committees, and is co-chair of the Australia-New Zealand Hip Fracture Registry. Jackie, thank you for joining us. You run a service to prevent falls. You look after people who fall, and you also do research with a particular focus on falls in people with cognitive impairment and dementia. Can you explain to us the link between cognitive function, postural stability, and falls?
Yeah, sure. Good afternoon, everybody. I think in answer to your question, Carole, it's probably easier to try and think about how it is that we manage to stay upright and then consider the role that the brain plays in staying upright. So as human beings, we are inherently unstable on two legs. We would be much steadier and less likely to fall if we went round on all fours. So staying upright is incredibly complex. No one can stand perfectly still. We are constantly adjusting our position in space. And how we do that is we have information coming in all the time in terms of vision, our vestibular system, our peripheral nervous system, which sends messages to the brain telling us where our body is in space, where there's an obstacle about to come up. We then need a brain that is able to process that information quickly and accurately, and then it sends messages down our spinal cord to our muscles that allows us to constantly adjust our position in space. And so that's a really complex set of interactions. And so for somebody with dementia, that ability to process the information in the brain in a timely manner is often slowed, and accurately in terms of a correct step that we need to take, it's often impaired as well. But you can see how lots of different, even age-related changes, but diseases can also impact staying upright as well.
I get it. Yeah, very complex process. Hip fractures, let's move to that for a moment. They're obviously a particularly serious consequence of a fall. And something I learned from you is that 40% of people who fracture a hip also have dementia. And you've been part of the largest randomized controlled trial in the world, exploring interventions for people with these deficits. What did you learn?
Yeah, so a large number of people who come in with hip fractures do have cognitive impairment. And so we are really keen to try and pilot interventions that prevent falls in this really important and increasingly important population. We know that exercise and occupational therapy home assessment in a cognitively intact population has been shown to be effective in preventing falls. What we haven't been able to demonstrate so far is whether that application in a cognitively impaired population would be effective. And so that's what we did. We tried exercise and looking at safety in the home to a group of 309 participants with impaired cognition. Of course, their carers were absolutely integral to this whole process. And we delivered an exercise and occupational therapy home assessment and intervention over a 12-month period, and really tried to understand what the person's preserved cognitive abilities were, playing to their strengths. So there's some people with cognitive impairment and they are perfectly capable of reading an exercise booklet and following instructions, but there are those who wouldn't be able to follow written instructions but able to look at pictures and do the exercises from pictures. And there will be some where actually somebody else needs to demonstrate the exercises to them. So we really tried to focus our interventions to the needs of those individuals. And unfortunately, after 12 months, we weren't successful in reducing the rate of falls. What we did do was reduce the number of people who fell multiple times. But the other thing that we got from that particular study was, at baseline, those people who were physically better at baseline, they did benefit from the intervention. So it begs the question for the frailer population, whether the intervention itself was actually intense enough or whether it needs to go over a longer period of time. So we've answered some questions, but we've actually asked a number of questions as well from that study.
Well, more work to be done. Yeah. There's another arm to your research though, and I love this one. People often think of the impact of research only in terms of a new drug or treatment. However, I think some of the greatest impact comes from improving health service delivery through findings from linked data. So tell us about the Australia-New Zealand Hip Fracture Registry and what it's achieved to date, please.
So the registry runs through NeuRA, and the whole purpose of the registry is to harness the power of data to drive improvement in clinical care for hip fracture patients. If you don't measure how you're performing, you don't know how you stand, how you benchmark with other people, where you need to improve. And so the registry collects data from all public hospitals across Australia and New Zealand and demonstrates how they perform against a set of agreed national indicators. So as a few examples of the indicators would be, how well do we manage pain in somebody who comes into hospital with a hip fracture? So really important from a patient experience perspective. How quickly are we able to get people to the operating theatre to fix the fracture? How quickly do we get people out of bed to give them the chance to recover from the hip fracture? And how often do we think about preventing the next fracture by getting people on treatment for osteoporosis? And just by collecting and sharing that data in an open public domain, we're starting to see improvements in a number of areas. Pain is certainly being better managed. We're getting more collaborative working between orthopedic surgeons and geriatricians. We're seeing more 7-day-a-week therapy services available. So it's great to watch the change over time.
In fact, your most recent findings, you touched on two of them then, were around early mobilization after surgery and also prevention of another hip fracture after the first. What does the data tell us there?
So every year we just pick out a couple of themes that we think are important to highlight. And so this year we've looked at early mobilization. So we know that prolonged bed rest is associated with lots of complications. There was a surgeon decades ago now in the UK who used to call bed rest rehabilitation for the coffin. So there's lots of bad things that happen if you leave people in bed: pneumonia, clots in the legs, pressure injuries. And so the goal really is to try and get somebody up as soon after the hip fracture has been fixed as possible. And up until this year, the indicator was, were they offered the opportunity to start mobilizing the day after surgery? And physios were saying to us, but actually what we actually need to know is not were they offered, was actually, did it happen? So we reported both this year. And whilst 90% were offered, only about 49% actually bottom left the bed. So there's a discrepancy there, and it's an important discrepancy. So we really do want to be able to get people out of bed. And it's not that the patients are not able to do it. So we know in the top performing hospitals, over 95% of patients, the bottom leaves the bed the day after surgery. And there are some hospitals who are doing mobilization the same day as the surgery. And yet there are other hospitals sitting down at about 20-25%. So room for improvement there. And the other area we looked at was preventing another fracture. So we know that it's really important to get people on treatment for osteoporosis. So an older person who falls from standing height and fractures their hip, they should be offered treatment for osteoporosis. And yet we know that only about 25% leave hospital on treatment. And that hasn't shifted really over the last few years. So we're going to be doing a sprint audit in November. A sprint audit means we collect a little bit more information for a very short period of time to try and understand what those barriers are. And then once we understand what the barriers are, hopefully we'll be able to get on and do something about it.
I like the sound about the sprint audit. All right, thank you, Jackie. I might leave it there and move on to Kim. So now I'll turn to Professor Kim Delbaere. Kim is a physiotherapist by training, Senior Principal Research Scientist, this is a long title, and Direction of Innovation and Translation in the Falls, Balance and Injury Research Centre at NeuRA. So Kim, I know you shared with me that as you were growing up, you had a lot of older people around you, great aunties, grandmas, and you developed an interest in the transition to old age, and you became known as the exercise girl. In terms of falls, how much difference can exercise make?
Yeah, thanks, Carole. Yeah, exercise it's a single most effective strategy to prevent falls. Like we know there's lots of things that we can do, like making your environment safe, having a regular review of your medication, and there's different things, but exercise is the single most effective strategy that will help everyone. And it's not just good for falls, it's got other health benefits as well, of course. It will improve your cardiovascular health and your mood even. But the one thing that we should point out in relation to exercise for falls prevention, that it's not just any exercise that will prevent falls. It has to be the right type of exercise and also at a high dose. And if we're thinking about the type of exercise, it should be balance exercises, so and challenging balance exercises, so something that you find difficult. For example, like think of trying to stand on one leg for 10 seconds, 30 seconds, or being able to step up a curb without having to hold on. So those type of activities, like exercises that make those type of activities easier, is what we're after. And we're not talking about just doing that once a week or twice a week. It's actually a dose of about 2 hours a week that we're after. And that is what we know will, in combination, will reduce falls if you can keep that up for about 6 months, and preferably as long as possible. And like in a way, like it sounds like a lot, but it can be divided up any way you like, and so you can make it feasible. But yes, it is the single most important thing that we can do to prevent falls.
Okay, and I know another one of your research interests is fear of falling. So what have you learned about the impact of that and how to address it?
Yeah, very early on in my research career, like as a very fresh PhD student, I became really intrigued by fear of falling. And the reason why was really when I discovered that fear of falling was more common than falls itself. Like we know as in numbers, like when we think about numbers, that about 1 in 3 older people aged over the age of 65 will fall once a year. But if we ask about fear of falling or concerns about falling, it's about twice as common. And that really got me thinking, like, why is that? Like, why? So does that mean that it's not falls that is actually leading to this concern? And it also got me thinking as to whether it was a good thing or a bad thing, like if it is actually, if it protects people from falling or if it does the opposite. So that is really what brought me here as well, Carole, to Australia, is to explore this. Like for anyone wondering where the accent is coming from, which I will never shake, but it's from Belgium. I'm Flemish speaking as a first language. So, but that is what brought me here, to try and understand this. Like, is do we actually increase falls through fear of falling, and that's what we found. So we saw that when people were more likely to be concerned in more challenging situations, that they changed the way they walk, and they walk a bit less smooth. And as a result of that, they might also be less efficient in reacting when something happens that they might need to take a protective step, for example. And as a result of that, they might increase their risk of falling, and they might fall more, and that really ends up in this vicious circle. So it's always been really a pet interest of mine, and it still is. And we're actually running a trial at the moment as well, where we are looking at how we can find the best way to kind of reduce that or normalize that fear of falling. And we are combining exercise, which we know is very good to really increase that physical activity with greater confidence. And we're combining it with a cognitive behavioral therapy program in collaboration with the Black Dog Institute to really improve the skills really around.
And that's the Own Your Balance trial?
That's the Own Your Balance trial, that's right.
Okay, we'll be mentioning that when we send you the follow-up email after the webinar. Okay, and Kim, you've also distinguished yourself by developing novel methods of applying technology to the challenge of preventing falls and maintaining mobility. So let's talk first about your Standing Tall app and the results of the trials that you've done there.
Yeah, what we try to do, so I'm a physiotherapist by background, and like with lots of research from our group, but also like all over the world, we know that exercise is the single most effective strategy, like we already spoke about that. But there is one challenge, and I don't think this will surprise anyone who's listening, but that is that we don't get people to take it up. And this is actually something that I saw firsthand with my grandma and my great aunties. Exercise was just not something that they did. It wasn't something that they had as part of their routine. They had never done exercise. They had very busy lifestyles, taking care of a family, but not exercise as such. So when that busy lifestyle falls away, like the activity falls away, and there is no replacement with exercise. And so that's really like a big part of my research, is to try and find ways that makes it easier for people to do these exercises. So to do these balance exercises every day for as long as possible, in the most convenient way, like in your home at a time that suits you without the need to travel. And that is why we developed Standing Tall. So Standing Tall it's an app that can be delivered through an iPad or through computer. And it gives you exercises that are tailored to you. So we do a balance assessment. We just make sure that it's all perfectly done. We delivered that first kind of introduction now through telehealth, thanks to COVID, and that's been going really well. And that way we can really set it so that the exercises are suited and tailored to the person who's doing them, and they also progress with them, so they become more difficult if you're getting better, or if something happened that maybe you haven't been doing your exercises for whatever reason. It kind of will get a little bit easier. It's just to make sure that's always perfectly the right balance. And we've done multiple trials, but one particular one that maybe I'll just quickly run the results by you is one that was recently published in the British Medical Journal in 503 older people living in the community 70 and up. And we asked people to do the exercises with Standing Tall for 2 hours a week for 2 years. So that's a very, very long time. And what we saw was that people did the exercises. And as a physio, like if there are any physios listening, like it is one of the hardest things to do, to actually get people to do their exercises and keep them up. But we saw like at 6 months, like 85% of the people were doing their 2 hours, which is unusual. And 68% at 1 year were still doing their 2 hours of exercises. And then at 2 years, we still had over half doing that 2 hour dose. So it's a proud moment, really. So we've achieved something. And even more important was that we were able to prevent falls. So after 2 years, we were able to prevent falls and also injuries from falls by 20%. So we hope now to actually be able to bring this to everyone to use.
I was just going to touch on that in the sense that I expect that people will immediately start asking where can they get it, but they can't get it yet, right?
No, they can't get it yet. It's still a research app, unfortunately. It's one of those things that as researchers we can think of all these wonderful ideas and kind of make them happen, but then like we're not a company. We're not in commercializing is not necessarily our strong suit, and that's really where we're now looking and have found a little bit of assistance to make it happen. So hopefully that will happen soon.
All right, I'm going to skip on to our last question, just in the interests of time, very quickly. I know you're also looking at the use of wearable technologies to capture real-life data on key indicators like variable gait and to feed this data into clinical practice. How does that work?
Yeah, well, I think if you've watched the news recently, and also with the new iOS updates and all the smartwatches and smartphones that everyone has, like it's actually becoming like, I think we can say it's becoming mainstream to actually look how active you are and how many steps you take a day. And also, if you look into your health kind of app, of if you have an iPhone, it actually also gives you how smooth your walking is, and how your fall risk is, essentially. And so we are kind of interested in that from a research point of view. We have been for a long time. And we know that that type of measurement that we can assess in daily life is so much better than how we assess it in the lab or in a clinic. Because in a clinic, what we would typically do is we ask people to walk down a hallway, and it's like the perfect kind of scenario, unless something busy happens. But we kind of want to see how people walk in daily life and how they navigate like a busy shopping center, and walking down the stairs and getting up from a chair and making a turn in the kitchen, and so those type of things. And we can learn so much from that. Like, we can actually predict falls with that information, but we can also understand like what type of intervention would be really good for people to prevent falls as well. So it's such rich data that now, like, the technology is there to actually capture that, and it's cheap. Like, it's not that expensive anymore to wear that technology, to purchase that technology. And so we're now working with clinicians to actually find out what they would like to see as well, and how we can make that as easy and informative as possible, both for the clinician, but also for the person.
Well, if we think back to what Jackie told us about, that complex interaction of so many different systems keeping us upright, and then obviously becoming involved in us falling or recovering from a fall, absolutely, there must be a treasure trove of data. Thank you, Kim. I'll move us on to James now. We're going to turn to pain and the brain. Didn't mean to make that a rhyme, but Professor James McAuley.
You're not the first, Carole. You're not the first to make that rhyme.
Okay, good. Professor James McAuley is a psychologist, senior research scientist, and director of the Centre for Pain Impact at NeuRA. So James, your research is largely undertaken through clinical trials with the aim of building the evidence base to inform clinical practice. And you've focused on low back pain in particular. And you've got some findings in terms of what treatments don't work and what treatments do work. So tell us first about what doesn't work.
Right, well, that was really the first half of my career, I guess. When I first moved to Australia after doing my PhD in the UK, we spent some time investigating kind of the common treatments that if you have back pain, you might go and see a physiotherapist for your back pain, and then they might give you some treatment for that. That might be something called spinal manipulative therapy, where you lie on a bed and they press on your back to try and relieve to make the joint more mobile. Or they might give you some types of exercise, particular types of exercise that are specifically trying to improve your stomach muscles to try and make your spine more stable. They may also, if you go and see your GP, you might get some sort of medicine to try and dull the pain or to take the pain away. But we did a series of trials, a randomized controlled clinical trials, and found out that actually most of these therapies provide only very short-term and very small relief. So they reduce pain intensity by a very small amount. In fact, most of them reduce pain intensity in such a small amount that you wouldn't even be able to tell the difference. I can find that because I'm a researcher, but for a patient, they wouldn't even be able to tell that that's a meaningful difference. But if I can just take a tiny little detour for a second and just talk a tiny bit about clinical trials, because clinical trials provide the best evidence. I mean, we hear about them a lot these days, they provide the best, the reason we're mostly interested in, they provide the best evidence of whether or not a treatment works. So whether or not you should expect the treatment to be beneficial for you or possibly even harmful. So that's why we're really interested in clinical trials. And that's why I'm interested in them, because often if you're a patient and you get a treatment and you feel a bit better after that treatment, we don't know whether or not that's due to the treatment or due to some other things like placebo effects, you've probably heard of those, or just you're just getting better naturally on your own. So that's why we do clinical trials. And they tell us whether or not the trial, in the most unbiased or the most accurate way, whether or not the intervention that you've received is actually beneficial for you or maybe even harmful. That's why we're interested in clinical trials.
So what have you found then that is, I'm going to do it again, the role of the brain in pain?
Well, so a lot of that research, because it was all of the common treatments that you would usually get from a physiotherapist or an exercise physiologist or from a GP, most of those, as I said, have a very small effect. So that was extremely disappointing, I think, for us. We wasn't what we expected to find. We thought we'd find evidence that these interventions worked. And so we took a bit of a step back and thought, okay, well, what is the point of pain in the first place? What is it? And what's the point of it? And Jackie and Kim have both talked a bit about how complex the system, all the signals that are coming from your body on a constant basis. And your brain has to filter through all of those signals to try and find out what are important signals and what do we do with those important signals. And some of those important signals that I'm interested in they're called nociceptive signals, which is a horrible name, but actually what they are is threat signals. They tell you that there's a part of your body which is under threat. And your brain sorts all those out. And if it's enough of a threat, then you experience pain. That's the reason for pain, to tell you that your body's under threat and to motivate you to do something about it. So a lot of this action is going on all up your spinal cord and in your brain. And for people who've had pain for a long time, we know that their brains are responding to nociceptive signals that are at a very low level. So you're experiencing pain when there is no damage that we can find. Nobody's been able to find damage in a spine for someone who's had back pain for a long time. Your system is responding in a way, it's overactive. The alarm system is just ringing too loudly.
Oversensitized sort of thing.
Yeah, exactly. So what we hope to do is to try and intervene, to try and reduce the alarm signal, to try and turn it down, to try and to reduce the gain from the sensations that are coming from your body, or the signals that are coming from your body. And that's what we've been doing at NeuRA over the last few years.
So that's what you did with what we call the Resolve trial, which basically found some treatments that work? Yeah,
so one of the reasons that if you had back pain for a long time, and I was to touch you on your back, you would have real difficulty telling me whereabouts you're being touched on your back. And if I was to touch you with 2 fingers on your back like that, you would say, oh, that's just 1 finger. You'd have real difficulty telling me that that's actually 2 fingers. But, and that's because you've had back pain for a long time and your system is just overactive and it's not really being able to distinguish between these types of sensations that are coming from your back very well. So what we found is that you can train that and you can get people to detect those, the sensations in a much more accurate way. And the more you do that, the more pain reduces. We've also found that that if for people with back pain, they don't like thinking about moving, for example. They don't like thinking about moving because it's almost like Kim was talking. They're afraid of moving. So, and that being afraid of moving because they think that's going to damage their back even more, they've even become afraid of thinking about moving. So they avoid thinking about it. And if you get them to watch videos, for example, of someone playing golf, they don't like that. They think that's just a bit horrible. They just don't like to watch that. So we've taken a graded approach to that as well. So get people to think about moving, to watch some videos of people moving, and then to think about how to move in a more precise way themselves. And the more that they get better at doing that, the more the pain reduces. So if you put those 2 things together, the tactile acuity training, which is touching on the back, so they get better at that, more precise at doing that. And if you combine that with the movement training, so watching videos of people moving, thinking about it, watching people in the street bending over and carrying heavy shopping, the more they do that, the more they get used to that, the more their pain reduces. And that was surprising to us. We did this in quite a big randomized controlled trial at NeuRA over the last couple of years, and we analyzed the data just a couple of months ago. So we're getting ready to publish that paper, but the good news is when you put all that stuff together and you compare that to a group of people who had a placebo treatment, so they had a treatment, but it didn't work, and we knew that it wasn't going to work, it was inactive. If you compared placebo treatment to this resolved treatment, pain reduced significantly and above the threshold for you being able to detect. So people felt much better after the clinical trial compared to not doing it. So we're very excited about that. It's a completely new approach, and we'll be publishing. Watch this space. Well, you'll see me on television talking about this over the next year.
Absolutely hot off the press. Okay. My last question for you, slightly different. Low back pain, everybody knows, gets, and so on. But you're also investigating a rare condition known as complex regional pain syndrome. And you're recruiting for a trial for that. It only affects around 5,000 Australians a year, but frankly, to use a technical term, is bloody awful, isn't it?
Yeah, I think this is really bad. This is a very distressing condition. So for researchers and clinicians, they're often very interested in this condition because it's rare and it seems a bit odd. If you have it, it's very distressing and very painful. So about the work that we did a few years ago, we found that if someone falls over and fractures their wrist, for example, that's the most common inciting event. About 3% of those people, 3 to 5% of those people develop some odd symptoms. So they might get an operation, or they might have a slab on their hand so that they don't move it very much until their wrist heals. But their pain doesn't go away. In fact, their pain starts to get a bit worse and worse. They might get blotchiness on their hand. They even get some hair growth on their hand, some odd hair growth. Their nails look a bit weird, and it's described as exquisitely painful. Now, there are very few treatments for these people. As I said, clinicians and researchers tend to find it very interesting from that kind of scientific perspective. If you have it, it's horrible, and very few treatments. But we found two of the most promising treatments. One of them is very similar to the resolved treatment that I was talking about, and another is a drug. And that drug just calms the brain down, really. That's what it's, in fact, the drug is often used for people with very early dementia. But for people with pain, it just calms the brain down a little bit. So we want to compare those two treatments for people with CRPS. Now, so COVID is horrible, and it's been horrible for everybody. But what's it forced us to do is to put our clinical trials online, so that now we can recruit people from across the country in a way that we would never have been able to do, or in a way that we never did prior to COVID. So we're recruiting for that trial at the moment. If you know anyone with CRPS and they might want to, the treatment may not help them, but they can help other people in the future. If they want to help us, we can send the web link to everybody.
Yeah, we'll send that out in our follow-up email as well. Thank you, James. Given where we're running with time, I think I might throw the floor open now to questions from our audience, which I've got flooding into my little chat box here. So starting in no particular order, Kim, how did the participants in the Standing Tall study become motivated enough to commit to daily exercising for such a long time? Maybe it was the Delbaere factor.
Well, yeah, the team of research assistants who do a wonderful job in motivating, absolutely. And it does happen. It's actually, like, jokes aside, it is an important thing. Like, as a volunteer, you actually do kind of go into the mindset of actually doing something for the research. So it does have something to do with it. But no one does it for 2 years. So the additional thing is definitely our view is that we have a big variety of exercises. So we've got over 6,000 exercises in our app, which means that we can really tailor it, and the app can grow with the person as they get better. And that's how we kind of get the addictive effect, like to noticing that the exercises are getting harder and it's easier for you to do them. So that to me is the key, and having it very convenient. to do the exercises as well.
Okay. Jackie, one which I'm sort of going to orient to you here around what more could be done to incentivize hospitals to perform better. But we didn't get to touch on the Golden Hip Award. Do you want to comment on that?
There's the golden hip.
Oh!
So, I mean, I think a lot of the time we're very good at identifying things when they go wrong. But actually, the reality is in health, there are places that do really good things. And so the Golden Hip Award was awarded for the first time this year to the hospital that performed best against all our national clinical standards. So we had the top 10 hospitals, all of which will get a certificate. And then the Golden Hip itself was awarded last week. Minister Hunt was part of that, as was the Chief Executive of the Australia Commission. So the winning hospital was not the Prince of Wales, but we're in the top 10. But the winning hospital was Princess Alexandra in Queensland. And sadly, the hip's still sitting on my desk because we will not be able to see the Queenslanders for a little while yet. It may end up getting posted. But it was such a big deal to that hospital to have its performance recognised as being good. So yeah. And
is that the inaugural Golden Hip Award?
That's the first, but the first of we will do it every year now. It was a great event, and it's lovely to recognise.
I think that's a fabulous strategy. It's kind of the hip fracture equivalent of the Oscars. Thank you. James, probably this one for you, I think. Somebody has had a terrible time in terms of pain management with opiates. Question is, do many people respond as badly as I did, and are there better options for the future?
Oh, well, that's a really interesting question. It's also a very difficult one to answer as well, because very often if you take an opioid, then initially you might get some pain relief. You might just feel a bit better. The problem about opioids is the longer that you use them, the less and less and less relief you get. But the more you have to take to feel anything from them. They also have some side effects about effects on going to the toilet, etc., that are really very bad as well, and very make life difficult. Yeah, I think that there are people who have a very bad reaction to opioids initially, but most people get a little bit of an effect that kind of peters out after a while, but they still continue to use opioids and feel that they're a very important part of their pain management. Unfortunately, there are people who also that actually I can't remember what the actual numbers are, but there are a significant number of people who have an overdose of opioids every year in Australia due to taking them for pain. So they are no longer advised for people with low back pain. And what's coming down the line to replace them? Unfortunately, actually, the drug cupboard is a little bit bare when it comes to new analgesic medicines. And the clinical guidelines, these are guidelines that big professional bodies release around the world, and they advise clinicians how to treat people. Those clinical guidelines have recently, in the recent years, moved away from advising drugs to manage pain. And they've moved much more towards being active as you can be within the bounds of your pain. Now, I know that sounds horrible. If you have really bad back pain and you've just woke up and you can't bend over to put your socks on, why is someone telling me to exercise and be active because of my pain? And I understand how difficult that is. And I think the best thing to do in those situations is know that you can go back to bed, but the longer that you stay in bed, the longer the pain is going to last. That is the truth. So if you take things a step at a time, just a step at a time, think about what you've got to do. Think about the tasks, break them down into little bits of tasks and try and achieve those. And then hopefully you can get up and get on with the rest of the day, the rest of your day. So that's the best advice, I guess, that I can sort of give. And drugs do provide temporary relief, but it's temporary. And I think that that's the best thing to remember about drugs.
Okay, thank you, James. Quick question for Jackie. Good question. Does the type of dementia affect the type of mobility issue? Or I guess the type of, falls or mobility issues that you have?
There are two parts to that answer. So there are clearly different types of dementia. There are some dementias that are associated with higher rates of falls. So vascular dementias and Lewy body dementias, those individuals are more likely to fall, whereas Alzheimer's disease, lower risk of falls. In terms of intervention, we don't really break people down into dementia subtype. We try to think actually, how do we work with that individual with this set of problems, not defined by dementia, but this set of problems? They're impulsive or they're inactive or whatever. How do we work best with those individuals to try and get the outcome we're looking for? So yes, there's difference in terms of risk factor profile, but in terms of intervention, it's very individualized, our approach.
Thank you. James, I'm aware you've got a hard stop at 4:45. We've got a few questions still to go through. I hesitate to ask you to leave us, but would you like to leave us and we'll continue for a moment or two with Kim and Jackie?
Yes, thank you very much, everybody. It's been a great pleasure to talk to everyone today. Thanks, Carole.
Thank you, James. Okay, Kim, one for you here. Actually, we didn't get to talk about Fall Screen and Fall Screen Plus, so this might be the time to do it. But the question is, what's the best tool to identify risk of falling in the senior population?
Yeah, that's a good question. Yeah, so there are multiple tools available, and there are multiple tools validated as well. But at NeuRA, within the Falls Balance and Injury Research Center, we actually have one of the best tools available, and that was developed by Professor Stephen Lord, who is a director of the center, called Fall Screen, and it's able to predict falls with 75%. And we are now growing on that tool by adding other measures in relation to mood, in relation to cognition as well, just to make sure that we actually cover off all the different risk factors of falls that we can change. So that's really primarily what we're trying to do with that tool, is that we are looking at risk factors that we can provide an intervention for to reduce the risk of falling. But there's many others as well. That is the one that we mostly use in our research, and is very well validated as well. Okay, thank you. I might suggest that probably what we'll do with the remaining questions is, because we'll need to wrap up the webinar shortly, but we'll follow, my team will follow up and with Jackie and James and Kim, and we'll get answers for you to any remaining questions. But just as a quick last one from me, Jackie, your best tip for our listeners in terms of falls and fractures, or preventing them, I should say, I guess. Yeah.
I've of course got no idea as to the age group of who I'm talking to at the moment, but if you are older and you fall and break a bone, please, please, please talk to your GP about getting assessed for osteoporosis and falls prevention. Don't wait till you break your hip.
And Kim, we know your best tip is exercise, but anything you want to add to that?
No, staying active and stand tall. That's what I'm going to say.
Forever the exercise girl. All right. Well, look, thank you. At this point, it's my pleasure to wrap up this third webinar in our series of NeuRAtalks. Thank you very much to James, Kim and Jackie for sharing their expertise, and thanks to you for your engagement and input. Please look out for the follow-up email, and I hope you'll join me again soon for our last one for the year on the 3rd of November. Slightly different topic. We'll be focusing on where are we now with schizophrenia research. If that one's not for you, then watch out for our 2022 program launching soon. Goodbye for now.